So now we're going to move to our panel Q&A session, with all of our Legend Type 2 Diabetes participants. So I want to invite Fawn up, and she's going to help us walk through, at least she's going to lead us through that section, actually. Fawn, come on up. Sure.
So now we'll have some dedicated time for an open discussion about what we have achieved through large-scale network studies such as LEGEND hypertension and LEGEND type 2 diabetes, and what future directions we are heading towards. And we will, of course, highlight some success stories and maybe some tiny little failures or rooms for improvement. So we're really looking forward to questions from the audience, and we're really looking forward to some very open, inclusive discussion. But before we dive into questions and answers, I want to highlight that it really takes a global village to achieve something like LEGEND and similar network studies done at Odyssey. So in the example of LEGEND hypertension, LEGEND type 2 diabetes, we have 19 multinational data sources as data partners, and I want to highlight increasing engagement from data partners in Asia, in APAC regions, so it's now becoming less and less US and EU centric. And there is a huge diversity of the expertise on the LEGEND team, including clinicians, epidemiologists, medical informaticians, data engineers, statisticians, computer scientists, and many people on our team wear many different hats, so people don't just belong in one bucket. And if you feel like your expertise is not listed in this little circle, that means we need you even more. It doesn't mean we do not want you on the team. And as being showcased by the panelists here, we have a wide range of community stakeholders, governmental organizations, industry partners, and people from academia. So it's really a very diverse, very wide range of efforts that made all this possible. And of course, we want more people to join us to make this better, to expand this even farther. And another thing I really want to highlight is that we have had many early stage researchers who not only actively participated in the studies, but contributed as rising leaders. So I'm showing some of their really lovely faces here, and there surely will be someone that I unfortunately missed, and I apologize for that. I feel like this is really exciting that we are growing more talents, nurturing more talents while we grow our community, while we expand on the evidence and the clinical knowledge that we are able to generate. And here is our current list of team members on LEGEND, and I really hope that in the future we will keep expanding on this list of names, and the list of names will, at some future time, include yours. So now I want to invite all people who have ever participated in or contributed to LEGEND hypertension or LEGEND type 2 diabetes to be on stage. So if you see your name here, you should be on stage. If you don't see your name here, you should be on stage too if you ever played any part in any LEGEND studies at any stage. If you want everyone to stand or sit, is totally fine. A session. Can we have someone? Shorter ones. Please don't hide. Please come. So now what's going to happen is that if you have any questions to the Legend team about the Legend studies, or if you want to be a data partner but you don't know how to do it, you can ask a question, like if there's anything you want to know, or like if you're curious about the success stories or potential failures or already done failures, then please ask a question. So we have a mic over there, a mic in the middle, and yeah, let's get started, and we will have a whole team to answer questions and have a discussion with you. And when you ask a question, when you answer a question, please start with introducing yourself, like who you are, where you are. Roger, please.
Oh no, here it comes. Roger Carlson, Corewell Health. My question is probably for Claire and the Odyssey Evidence Network. You guys have talked, and all of you have talked a lot about, the research and the studies that you've done, and that's all well and good. But I'm an ETL guy. I put data into it, into OMOP. I don't get it out. That's not my job. But I wondered if you could talk a little bit about what the Odyssey, being part of the Odyssey Evidence Network, can help in terms of data quality, benchmarking, and for people on my side of the aisle. In other words, what's in it for me?
That's a very good question. Thank you, Roger. I touched very quickly on the Odyssey Evidence Network, and I hope many of you will join. But to Roger's point, one of the things we are trying to do in formalizing the network is we are trying to give back to you all who have data. So what we have learned over the years is there are some differences maybe in how we ETL, or maybe how we might map some concepts, or there's maybe you have some questions about your data quality, like Roger is saying, and that's part of what we're trying to do in the Odyssey Evidence Network. If you join us on this journey as a data partner, when you share with us some metadata about your database, you'll absolutely be available to join in a Legend study or something like a Legend study in the future. But it's also helping us learn from you about what type of data is out there, and then help you by saying, hey, here I observe, you have these concepts in your database. Have you thought about, maybe using these other ones that are more prevalent in the community? If you remember, Anna did this study where she was looking at concept prevalence across the community, and that has been a huge community resource. And that's just one example of the things we can do to help you with your data, and then also what you will be helping us in the community to generate even more reliable evidence.
I was always jealous of Patrick and some of the folks in industry that purchased some data and they didn't have the ability to go back and look at the actual medical records, and maybe they weren't involved in the actual translation from the beginning to the end. At the VA, we do all of that, and so it's super scary knowing that what you might put in might affect everybody's research. But for us, one of the things that we've really seen a benefit of is seeing what other results people got. And that allowed us to kind of go back and check and just make sure that, are we seeing these things because it's an artifact of our ETL, or is it a real difference? And so for us, that double check has been an incredible benefit.
Okay. Thank you so much for the question. Thank you for sharing.
I'll take a brief comment. Just to sort of second on Scott's comments, what I've found really valuable is, as we participate in the community, doing quality assurance with the projects, checking data, doing additional mappings, making sure that the data elements that are required for the studies are important. We actually feed those results back into operations, so that the cleaning of the labs, the cleaning of the meds goes out to hundreds of other research projects for reuse. So in that way, the Odyssey community is giving back to the data partners through the cleaning of the data.
Thank you so much for sharing the insights. So I want to direct the question to that mic over there. Please.
Hi, I'm Daniel Smith with Emory University. One of the things I really appreciated yesterday during the tutorial session, especially in the morning, was the summary of kind of this back and forth between the initial LEGEND study and Moran and colleagues, which was referred to as the mantra. And so specifically, it was the way it was summarized to us was the mantra is essentially this idea that observational data and observational research isn't necessarily worth as much without all of this to different checks and balances that are available in RCTs. So I was wondering, given the focus today on LEGEND, if there could be a new commentary by some of the folks up here to Moran and colleagues. We can certainly let the data speak for itself with LEGEND and everything that's been provided, but I was wondering if there were any pithy statements from folks up there that would like to respond to Moran and colleagues at this time. Thank you.
So we'll have Harlan or Chen taking the question.
So why do I need to answer to this very tough question? So whether observation study can replace the RCTs or it's very tough, and then but the approach of Odyssey is to conduct observation study with the best practice, and this is a very innovative approach because there is tons of the observational studies in the world, and then many of them actually I think are futile. And because we have access to the very large scale data network in the world, and then we can produce very large scale evidence from these data network, and then we may provide lots of the false positive findings from this data network. It's very easy to produce, significant findings from this large database. It's very easy to make a p-value less than 0.05. So we are against it. We try to evaluate the reliability of the evidence by using the diagnostics such as negative control outcomes or the balance or the PS equipoise or overlap. But I think that, in my humble opinion, we may need more experiments to ensure the reliability of evidence produced by the Odyssey. So even though it is current best practice, I think so, I believe it, but we need more evidence that whether it is how reliable it is. Really, and then how we can complement the findings from the RCTs by using observation study.
Okay. Yes, just to add to what Chan just said. So for the first LEGEND study, the hypertension study, we actually did a formal comparison of the results of LEGEND to the randomized trials, the meta-analysis of the randomized trials, and we actually found very good concordance, which wasn't all that hard because the confidence intervals from the trials were very wide, so we can easily fit inside of them. I think also we had the example where it was the chlorthalidone study where we first had the results and then later came the trial and our results very much matched the trial, except again the trial had very wide confidence intervals. Those two results are pretty hidden actually if you don't know where to look for them. So I think first of all we need to do a better job of communicating them. Also, in the meantime, we've evolved our methods, so now we have a much better grasp of objective diagnostics and applying them at scale, which we didn't have in LEGEND hypertension. So I think actually we've improved our methods and are improving still. And as Chan said, we actually needed to do a better job of now showing that we're even producing even higher quality evidence, which I firmly believe we do, but we need to do the research and then be more vocal about it. You want to do? Yeah. One thing. How you doing?
So I'll just say I don't think there's anything more important than this group being able to come together and articulate the clear and important principles that represent the highest quality of observational study design. Every day, 99% of observational studies are produced are terribly flawed, fatally flawed, and yet they still often make it through peer review. They come up and then they impugn the entire field of observational science. This group needs to continue its quest, as Martine said, it's a quest to continue to elevate the quality, but you also have to be able to draw the contrast. And I think the question was about commentaries. This group should be writing commentaries all the time that are exposing both what are the right ways to do this, how you can make causal inference, and what's the contrast with what is more typically done. Odyssey is one of the biggest secrets in the world. This is a group that's firmly committed to outstanding observational methods, and yet most journal editors don't even know what Odyssey is. If you can articulate principles like Martine and the Legend group has in the EMEA study, the EMEA publications, and we can disseminate that more broadly, where people will start saying, we are doing this research according to the standards of Odyssey. And, then I think that may change things. But ultimately, there's a great need for more knowledge generation. It's going to come from observational research. Whether it points us in the right direction or wrong direction is going to depend on the methods. This group is positioned perfectly to not only, perfect your own science, to work collaboratively in an open science environment to promulgate principles, but actually to move the entire field of science on observational research within clinical medicine. And that's what my hope is that this group will do.
Yeah, thank you for the beautiful combination of answers and then perspectives. So let's turn to the mic in the middle, and Kevin, please.
So Kevin Haynes, Johnson & Johnson. So to build on my question from the last panel that's now apropos to this group, Scott, I wonder if you have taken the results of Legend to the VA leadership, and if that then has begun to have the impact such that vets aren't having to come in, fail metformin, and then get SGLT2s or whatnot, and actually to the clinicians on the stage as well. Have we taken this to their P&T boards, local organizations, your local Blue, your Aetnas, your Optums, your whatevers of the world, to then say, this is the evidence, and now it needs to be implemented, and more also on a full benefit risk in this. This is the number that we need to treat with the cardioprotective to prevent X number of hospitalizations. So here's the actual bottom line dollar savings that you'll have. And oh, by the way, you were scared about DKA, and you shouldn't be. So have we put all of this into a packageable framework so that we can bring it to our clinical leaders and our local payers? And that goes to the governments as well. So in the countries that don't have the insurance, but taken to the government organizations to change the care based on the data.
I'll give you, while you're coming up, I just want to say one quick thing too about this. I do not think the similarity to the results of the clinical trials is the validation that we seek. It's about that the methods, and also compared with simulation. So I just want to, because you were also saying about I think both can be right, because in the real world there can be different results, and both can be right. It's important for us to see.
Thanks. Thank you very much. Great question. Let me just state that if you think it's scary that your ETL may affect how people do research, your study results affecting policy is super scary. But that is where we make the difference. I'll quickly state that in Legend, there was something like 4 million people, Legend diabetes, and the VA had something like 400,000 of those people. So what we were able to do is go to VA leadership. We will be able to go. We haven't done it for this one yet until it's published. We got 10 times the population that we would have if we had just done this in the VA ourselves. But I'll add one thing to the incentive structure. This is why participating in Legend is good for us. But as a community, I think we need to do just that. The incentive is to get a publication out. But I think we can each contribute in ways where we are taking it to our leadership and where we are advocating around the community to take these results and actually have them make a difference and reach our patients. So.
In my humble opinion, that one missing piece in the Legend Diabetes or the current Odyssey network is that we did not conduct the cost effectiveness study. So before implementing our evidence into the clinical practice, we need to make sure that whether it is really cost effective. And then I hope that one day someday we're gonna have some work group for the cost effectiveness.
Has there been a response from the cardiovascular program at Yale?
Oh, sorry. I mean, what I will say is right now it's what we found is pretty in line with the guidelines that are currently used. So we haven't really, I'd say, implemented specifically what we found recently in the second-line comparative effectiveness study, but it's already in line with the clinical practices that that's accepted right now. So.
Hypertension, we didn't make the progress. Right? Amazing. People still struggling.
Yeah. Deliver one.
And not just about the comparative effectiveness, but even if we are able to characterize the way, let's say, for example, some of the cardioprotective antihyperglycemic drugs are being used, it serves to act as like a real-time pharmacovigilance strategy to see whether the guidelines are actually being followed, how many of the guidelines are being followed, how the trends are changing from year to year, and how like different health systems compare against each other, compare against the national average that may be reflected in the US Open claims, and how do like specific healthcare systems stack up against the others across the world. Like we have data from so many European data sources, so many Asian data sources. That I think could be interesting, going even one step further than comparing different drugs, like more than comparative effectiveness, even the characterization of how these drugs are actually being used and not used could also.
Thank you for the question and this very nice discussion. Can I just add that, Kevin, it sounds like you're very enthusiastic about communicating the results through risk-benefit analysis, and maybe this would be a perfect entry point for you to join the LEGEND team so that we can further expand on this, and that applies to all the other people who might be interested in this in the future too. So let's direct the question to this side. Morning, please.
Hi everyone, my name is Morning from National University of Singapore. Before my question, please allow me to do the advertisement one more time. I'll be hosting the Odyssey APEC Symposium in Singapore between 4th to 6th December. Please do join us. Yeah, we have an exciting lineup and we have good food in Singapore, and rest assured, I will keep my promise I made last year. Anyone who comes, I will buy you a drink. Okay, still ready. Okay. And to the question, first of all, congratulations for the LEGEND team that you already have a very wide network of data partners for many of the studies. Also coming from an APEC background, is there any plans that we want to do more to encourage more data partners from low and middle income countries to be joining this consortium? I know for a fact that many countries in APEC, in low and middle income countries, they do have very strong interest to join many of the studies and to be on board of our consortium, but they face the reality and the challenges is that they may be lack of expertise, lack of manpower, and more importantly, lack of fundings. So in addition to what we have been already doing great in sharing our experience through this open science platform, we will be doing more as a global community. Thanks.
Can I? Yeah. Well, thank you for your question. I think what I would say, one of the important things, and one of the things that we need is more resources in low and middle income countries for mapping data, for example. So maybe having like an Eden in the global south is something, it's what we need right now. I think people need resources to get this done. There's a lot of will to be involved and participate, but of course lack of resources, I think it's the main issue. So I don't know how we could do some kind of Eden extension in the south, global south. I think that would be something that could help.
Yeah. So I just wanted to highlight. I think the Cynthia has been doing it. Cynthia and Andrew Williams, Cynthia Sung and Andrew Williams have been doing a fantastic job in the Africa chapter, really working to get many low and middle income countries to join us. I think it is a bigger lift for them, just given the nature of the data they have in those countries. But we do know that there's a lot of people in the community working towards that, and honestly too. we've got Andy over here and Cynthia just got the OMOP CDM recognized as a global good, which was a huge deal if you haven't heard about it. And it will actually help some of the governments and some of the low and middle income countries come on board with us and provide funding to some of those data partners who need it.
Maybe I could actually just follow up, because that was that was partly my question, and you actually announced what I was going to announce as well, so we covered it already. My name's Andy Cantor. I work for the Columbia International eHealth Lab, CL. It's interface terminology, which we hope will bridge the gap between the types of data sources that are in low and middle income countries and the Odyssey terminology and OMOP dataset. The key value that, and Atif, maybe I'm going to ask you to comment on this, but one of the key values of the Digital Square's certification of the CDM as a global good was the idea that these types of global goods are typically not funded. You know, people have particular use cases, they have particular infrastructure that they want to fund, and that they're trying to draw attention to global goods, kind of the data commons or global commons for support. And I think industry has a particular role to play in helping increase the representativeness of these studies by improving the data participation of those kinds of places. And the ministries of health in those countries, who ultimately kind of govern access to most of that kind of data, are going to be very concerned about where that data is going and how it's being used. And industry has traditionally been viewed in those areas as suspect. And yet there's an opportunity here for that data to dramatically improve the representativeness of the data being used by industry. So is there a non-quid pro quo kind of approach that you see industry be willing to support these global goods? I mean, obviously they've been supporting Odyssey in terms of the network and the people and to some extent the tools, but specifically in those kinds of low and middle income countries in a way we could raise the profile, because I think the resource problem, I mean, we give it lip service. It is a fundamental problem, and it's not just about people in those countries, and we can help support those, but it's about paying for servers and paying for the mapping and support for that kind of thing.
And that's a great question. And there's specifically an industry work group that Paul and Muri lead that's tackling that problem as well. And you're absolutely correct. I think there's a way for industry to be better involved in both in terms of guiding the need for resources and data coming out of those countries, but also supporting the development of those regional data hubs and learning environments as well. It's almost beneficial from our perspective for industry to be more involved with Odyssey in driving those efforts, because Odyssey can be that central glue that helps accelerate or optimize those efforts rather than industry having to build those out themselves. So I think it's a conversation in place that the industry work group's having. I think the key structure is how do we build a model that can be scaled, replicated across, that doesn't lead to a real-world evidence space for industry to play with and real-world evidence for academia to play with, but a space where everyone is able to use the same resources effectively.
Sounds like a good idea.
And it sounds like it's a conversation that will just keep going, hopefully during the symposium too. Thank you for the question. And let's go to this side for the next question.
Andrew Williams from Tufts. So as a person who's a great admirer of Legend and its landmark achievement, it seems like in order for it to have the clinical impact it should have, is a communication challenge that you all have been meeting, and we're seeing some of that today. But how do you get to the bottom line conclusions when you produce so much evidence? It's people coming to a typical journal paper will have certain expectations about what gets presented and how to make sense of it that you all have to kind of challenge. You have a challenge in dealing with. It seems like there's also one on the method side. In order for the LEGEND study to have the impact on methods that it deserves to have, you all packed a lot in, right? It's done differently in a bunch of ways, not in just one single easy to understand way, but in multiple ways. And the LEGEND principles paper articulates it well, but it's not easy to sort of say what's the most important thing here? What's the key thing that's better about observational research? If you had to boil it down to in a similar way to Cynthia's question and Kevin's questions, we're trying to boil down, like, what's the bottom line here? What do you do policy-wise? What do you do clinically? Is there a reflection on how, is that just an inherent level of complexity the methodologists, observational methodologists of the world have to live with? Or is there a way, do you guys have somebody want to answer about it? What's the most important lessons learned so far? Where do you see the most bang for the buck in improving the state of observational research methods coming out of LEGEND?
So I wasn't quite sure if you were asking about how to communicate what's better about what we're doing, or...
Yeah, if you had to draw it, I'm giving you two options. One is, there's no reducing the amount of complexity. Like, yeah, it's complex. We did things in a bunch of different ways. Live with it. Try and learn all of them. That's hard, but maybe that's an obstacle to like having the impact, is because people don't deal with complexity well. Having to learn multiple things at once is hard, right? If you're going to change the observational community's approach to research, giving them a single lesson is more likely to be actionable than learn these 10 things and do all of them at once. And so if that's true, what's the most, the people live with that, or is there like one or two things you think people should?
All right, so I'm actually going to steal from George, because George actually summarized the 10 principles into two. If I got them correct, they're transparency and verification. Yeah. Yes, so I think those are the two key parts of what I think makes Odyssey generate reliable evidence. So transparency, you pre-specify what you're going to do. You are very explicit about what you have done. You have open source code so everybody can check what you did. And so the whole process needs to be transparent and pre-specified. And then verification, my favorite part, is we need to check all the assumptions that we're making. And so that's what we do, for example, with negative controls. Or actually, have we dealt with systematic error? And it's what we do with our objective diagnostics, is we actually now have formalized a lot of the checks that we're doing for all of the assumptions that we're making. So that, to me, would be the key takeaway. Unfortunately, it's not one, it's two, of the lessons that we've learned and have implemented. Yeah, go ahead.
So you're brilliant. The message still isn't getting out to the public, right? And I think the question is, like, what's the kernel of this? So transforming what that is into consistent messaging by this community. And that means, like, I don't know, where are the TikToks that are saying this study's got issues, this represents good science? I mean, if it's a movement, you have to start communicating. But I'll tell you what, the reason I want to say is I have great admiration for this work, but the thing that blew me away was the reproducibility approach to this, which is we're going to do a comprehensive, every single different thing that we can do, and then we're going to show the distribution. And we're going to show the dots where, like, somebody who's cherry picking is going to, if they're going to p-hack, they can take this one and make it a big article. But we're going to show the whole distribution of results. And I still don't think this community has made that point clear enough, that's the problem. Lack of pre-specification and then just publishing means nothing if you know that you can do it 1,000 times and you're going to get some sort of probability distribution of results based on the assumptions that you're going to embed in the studies. And that's the Achilles heel of observational research, is that everyone else is saying, what's the coolest finding I can do and how can I sell it to publish it? Instead of trying to understand what ground truth is as much as you can. And to me, that was the biggest accomplishment. I mean, all the other technical stuff, the being able to do the risk adjustment, the verification, all this stuff, and then Patrick, when you showed me you could produce a paper by pushing a button and say, which paper do you want? Oh, you want a paper on this dot? You want a paper on that dot? Like, we've got to get this message out that this is what differentiates this group. And in my mind, that's That's a special sauce, I think.
I'll try to add, and I'll use this as a testing ground because I'm trying to think about ways to communicate this to even my own division of general internists or wider Department of Medicine. And in the sense that, Martin, you kind of felt you stole from George, I actually would explicitly steal from you. And I don't know if this gets too technical, but everybody has their observational data set who does this work. It's generally kind of graded on how deeply you know this cohort. But the piece that I think is just should be blindsiding the whole community is what the work you've done in negative controls. If people could take that as the single lesson, that we don't actually know what systematic bias we have in this database until we run this experiment, then the need to compute at scale is entirely self-evident. Everything falls from there. It's the first domino. Then you have to look into large-scale propensity matching if you're going to compute at scale. You have to use Mark's methods in cyclic gradient descent because you're not going to build them yourself, I promise, right? And if the wider clinical community could realize that, right now, just to give you an anecdote, what I remember when I was training, one of the docs I was working with, who was an accomplished researcher, said he ignores observational results that have an odds ratio of less than 2. Because he needs some kind of bandpass filter, right? Because so much of what's published is false, right? So people realize there's a problem there. My feeling is that at least that would be that's the one step that has to be accepted for that to start to change. And Nicole, actually I wanted to hand the mic to you because we were talking last night about this issue and there was one other thing that you'd mentioned about your role as a journal editor. And other ways this community could contribute. And I thought instead of using your words, I thought you maybe just would take them yourself.
Okay, thank you. We were talking about this issue of dissemination of evidence and how do we get this evidence out there. And Harlan talked about just one study, one estimate, let's publish it. We're getting so much of that now in observational journals that it's so hard to find reviewers, right? So I can't find reviewers. And we as a community really need to address that. And if we want our studies published, then we also need to take on that activity of reviewing papers and rejecting papers that do not address the principles that we are trying to develop. And I think that is something that's perhaps sometimes overlooked in the work we do. We have a responsibility to get good evidence out there and published. And unfortunately, one of the things with that is taking responsibility for editing and reviewing those articles that come across our desk. So if I can implore you all to please say yes to me when I ask you to review.
Thank you. That's a great message. And in fact, the session after lunch is directly relevant to this. And one of our big steps is working with a family of journals. And Harlan, thank you for pushing that forward and for all of you on the stage who are part of that process. I just want to point out not to get discouraged. So you win when we have the truth and we're persistent. And that's what's going to get us there. So, take ACE versus ARBs. Everyone knows that ARBs are better. They're invented to improve on ACE inhibitors. We don't have the big randomized trial. We did our study, and independent groups picked it up and published editorials saying, this is all we need. We can make the switch now. Let's change the guideline. But it's going to take years. My provider, uses ACE inhibitors because they're familiar with them. They don't want to make the switch to ARBs, even if it's slightly better, because they're afraid of what they might do to someone with less familiarity since they're so familiar over the many years they've been practicing. So it's a slow process to move over. We have to stick with it. We have other examples where the research community has a vested interest in one side, and then it's hard to get over that hump. And then it takes the ARB versus ACE inhibitor is the easy one because we all know it's true, and we're still having trouble getting over there. Like you use the example, the chlorthalidone versus hydrochlorothiazide. That's one where the research community is still not convinced despite 10 years of studies, 5 large observational studies, and 1 randomized trial. And if we can't get them convinced of the randomized trial, you're going to have to get over bias, and it's going to take time. So we will have to approach it, unfortunately, from multiple sides, the journals being part of reviewers, publishing editorials, and just publishing those studies. They are getting published. We're not in the situation where they won't accept our studies. we're in Lancet and JAMA and BMJ, so we're in the good journals and we're getting there, and that's part of this wave forward.
So one thing to add is that the experience that we had for disseminating our results for comparative cardiovascular effectiveness of drugs. And so we aimed for clinical journals, and I think it takes to make a coherent and consistent story out of your results. We don't want to confuse the readers that, oh, we have done so many robust methodologies to make sure that the results are consistent. But we, at the end of the day, we published all of the diagnostics and everything that we have done. But we put the results that clinicians can make the most connection with in the main manuscript, and then try to somehow make it more clinically relevant to say that, oh, so we've done this propensity score matching so that the clinicians can make sure that, okay, so these guys know what they are doing, they have addressed these biases. And also, we've mentioned, we tried to mention that how we addressed other sources of confounding biases. So I think it's also our responsibility as clinician scientists to make sure that the story is consistent and not confusing.
And just adding on to that, just really quick, I think something that we could, as a group, do a lot better is providing communication pieces that meet the needs of the stakeholder. There are clinicians, there are clinician scientists, there are peers, there are providers, there are policymakers, and all of them take the same evidence and read it differently. And I think rather than just be an afterthought of saying, I published and that should be enough for all the stakeholders, I think we need to go a step further in creating the disseminating storyline that meets the needs of a policymaker that's very different from a clinical provider versus a payer. I think that key of translating or interpreting the results forward for the needs of that stakeholder is really what's going to drive this community from taking the paper into all the aspects that we want to go towards, guidelines, payers, policymakers, etc.
Yeah, just want to add to that. I think there's multiple ways we can improve the dissemination of the research and communicate with clinicians. We already mentioned publish in high-impact clinical journal with summaries, and also the infographic like tailored to the different stakeholder, like the gentleman just mentioned. And as Odyssey, we are also doing publishing like all the result in our Shiny app, so it's user-friendly, interactive online website that allow the user to really select what comparison group they're interested in. And I also feel it's important to partner with professional society, like for Legend Hypertension, maybe partner with American Heart Association, American College of Cardiology. For Legend Diabetes would be American Diabetes Association. And maybe for clinicians, they're providing some workshops and provide CME credit, like continuing education credit for the clinician, for them to more education for them to learn what is considered as good observational study compared to other in the literature. That would be helpful.
Thank you so much for this very, very informative, very, very helpful discussion. So with respect to time, we cannot take more questions, but I think this is the perfect cue for the session after lunch, where we will discuss a collaboration with Jack and various professional associations. And thank you all for the amazing questions, and thank you all for the amazing answers. And we'll adjourn for lunch, and then please come back for more discussions.